to briefly review the innovation planning process and the resulting 5-year plan for Washington at a high level, and take a look forward to development and implementation of the innovation plan strategies, and time permitting, open a new round of dialogue with webinar participants. I thought I'd first take a quick look at what we said we'd do in our first webinar. So in that time, we said we would include goals, strategies, and tactics that are focused and aligned. We said we'd create a 5-year plan that will spread innovation over time to serve the majority of Washingtonians. We wanted to ensure that we could measure and evaluate progress, consider cross-cutting systems, capabilities, and interventions that support multiple populations and communities, focus on strategies that have demonstrated ability to improve health outcomes with lower cost or are very promising, focus on strategies that can be sustained after any potential future testing grant funding has ended, aim first where there are indications of system and community readiness, and support a culture of innovation, learning, and community collaboration among and across government and private organizational settings. With your help, we've now developed a plan that meets these goals. The State Healthcare Innovation Plan will have a profound impact on individuals and families across Washington State. We expect that a fully implemented innovation plan will achieve an estimated $300 million return on investment in the first several years. Washington will lead with other health purchasers and payers as a first mover towards a healthcare system based on value and outcomes instead of volume. We will see regional collaboration that will promote healthier communities and improve urban and rural healthcare delivery. We expect our communities can be healthier through comprehensive prevention strategies and early mitigation of chronic disease. And we hope to see many more of our most vulnerable Washingtonians receiving improved care of chronic physical and behavioral health conditions through better integration of clinical care and social support. We also anticipate that this bold plan for healthcare innovation will yield savings in other areas of the state budget, from criminal justice, education, family supports, to other social services programs that are directly affected by and ultimately tied to the success of better integrated healthcare delivery systems and social services and more fully engaged communities of health. Next slide, please. As a reminder, this is always our reminder slide, development of this plan positions Washington as well to apply for an anticipated second round of major Center for Medicare and Medicaid Innovation State Innovation Model Testing Grants. This next funding opportunity announcement is expected to be significant in terms of the size of the grants, potentially up to $50 to $60 million per state, and the announcement is expected in February. But the firm date and the contents of that funding opportunity announcement have still not been revealed by CMMI, and they could be significantly different from round one. We simply don't know yet. The one thing that we have observed is that the CMS, the Center for Disease Control, and other federal agencies are more closely collaborating at their level and share our vision for a future that more closely meshes healthcare, population health, and the wider determinants of health. Next slide, please. That's great news because it reflects the path Washington has chosen and our focus on cross-agency and systems and health in all policies. This is reflected in our ongoing governance structure that you see here, our consultant and staff teaming that has occurred, and in our public-private consultations as well. Next slide. In fact, Rhonda, you can advance 2 slides. This is just in terms of participation. We could not have asked for a more engaged group of thought leaders and contributors. Here are just a few of you. And then if you could go to the next slide, Rhonda. Here's a picture of our planning by the numbers. And you can see in a relatively short period of time how extensive that participation has been, and it's just been an incredible journey. Next slide. So our planning process was continually informed by feedback received from the feedback network during presentations, formal and informal conversations with leaders, staff, and consultants. This feedback has significantly shaped the thinking that went into the plan about the structure and elements of that plan. You may all remember as well that the draft, when it was published at the end of October, was truly that, a draft that reflected a great deal of work and effort, but that intentionally was not set in stone or editorially polished. We received nearly 100 letters, emails, and survey responses on that draft. The comments were positive overall, with support and encouragement for the general approach outlined in the draft plan and the state's inclusive and transparent planning process. Many comments focused on the need for more specificity and a desire to balance flexibility and alignment. Much of that constructive criticism was particularly valuable, and you can find the themed comments in the design process section of the innovation plan. These comments and subsequent engagement helped us pinpoint and focus on the issues of greatest concern and areas most in need of further refinement or change. I'll share with you that releasing a draft that really is a draft is a good way to both test your self-assurance and develop a better end product. Thank you for trusting us to listen. Thank you for providing your honest feedback and helping us build a plan that begins to bridge us to a learning health community. Thank you in advance for ongoing engagement, recognizing that completion of this phase of planning is the beginning of a journey and is one that will include an ongoing cycle of plan, do, check, and adjust as we go along. Next slide, please. The transformation that we're working to accelerate is important to our personal health, the health of our communities, and our state as a whole. I'd like to turn to Dr. Bob Crittenden now to help frame why this plan is a priority for Governor Inslee. Bob?
Thank you. Thank you very much. It's Bob Crittenden, and I appreciate the opportunity. As you all know, this has been a long process. Many things we're discussing now are
Muted it.
Good, thank you. Apparently I was muted. The things we're discussing now are things we've all been talking about for years, but we're trying to make sure that they are in the proper order, that we know more about them, that they make a difference for our population. As you all know, healthcare costs have been going up, and without intervention, we're going to have those costs impinging upon other priorities in the state. And as everybody knows, we have education, transportation needs. If we don't act, we're going to be faced with trade-offs that we don't want to make. By 2017, the state will be probably the largest purchaser in the state, with about over 2 million of our residents having health care purchased by the state. The state has a responsibility to be a good and prudent purchaser of that health care, and not just for the funding, but also for the outcomes and for the improving the health of the public. With that purchasing power, though, comes the responsibility of making sure that we help the system and provide the incentives that make the healthcare system efficient and effective, provide the best care for our population. So why do we want to change now as opposed to 20 years ago? And one of the reasons, obviously, is that we do have this cost problem, but we also have problems in the delivery systems. We know that there are a lot of silos in our system, a lot of pockets of funding having to do with behavioral health, with medical care, and things that impinge upon the health outcomes of our population, such as housing and other social supports. We also have great barriers because of that, where we aren't able to coordinate the care that needs to be coordinated because of our funding streams. And we also reward fee-for-service. And as we know, that fee-for-service is great at delivering more widgets, but not necessarily providing the coordination and integration that's needed to improve the quality of care. So next slide, please. An example is that we know that people with behavioral health die 25 years younger than behavioral health problems die 25 years younger than those people who are who don't have those problems. And they don't die of behavioral health problems. They die of medical problems, cardiovascular problems. So we have a responsibility to not only look at the way we pay for it, but how we integrate it and make sure it works appropriately. Next slide, please. In the last 20 years, our healthcare costs have gone up. In fact, the last 40 years, they've been going up about 7% a year. But just between 1991 and 2009, our healthcare costs per capita in the state went from $2,300 to $6,700. Now, a family has to pay more out of pocket for its healthcare than for a mortgage payment. This is compelling to the state as a whole, but it's also compelling to families, individuals throughout the state. Next slide, please. After this period of 8 months of looking at this, we feel, and the governor feels very strongly, that while we've done very well with expanding access in the state, and we will continue doing that, we need to ensure that the cost and the quality of care is improved as well. We appreciate the planning process, the involvement of the different groups who participated in the planning. I think it's a very fine product, but it's also one that we can, in a methodical and appropriate way, implement those parts that are able to when we can do that. So we actually have legislation before the legislature this year to start some first steps. The things we're going to be looking at are going to be greater transparency, empowered communities, and integrated whole person care, which includes behavioral health. And we're looking forward to your input and support as we move forward on that. Thank you, Karen.
Thank you, Bob. Before Dorothy, Peter, and John Weepson get into some of the details of the plan, I'm going to give you a quick and dirty overview of the structure of the plan itself, because as you look at the plan and you try to digest it, it'll be more, I think, easily digestible if you have this framework in mind. There are 7 essential building blocks to the plan and 3 core strategies. Those building blocks support the 3 core strategies and work together at this end to move innovation forward. Next slide, please. One of the things that's really notable about this as a plan for Washington, it is a health plan, not just a health care plan. And it signals Washington's serious intention to move from a sick care system to a system that focuses on prevention of disease and strong linkages between communities, public health, and the delivery system for the reason that is illustrated in this diagram. Next slide, please. So what's in the plan? Here are our 7 building blocks. And these 7 building blocks are critical because transformation depends on the development and strengthening of these fundamental capabilities and supports across Washington's health system. These foundational building blocks enable Washington to realize our 3 transformative strategies to accelerate change at the delivery system. See those out a little bit more about at least some of these as we go along. And I won't go through them. I think this is a pretty readily digestible list, and if you've been following innovation planning, we've been talking about these pretty consistently throughout. Next slide, please. So in terms of our 3 core strategies, as you may recall, we really focused our work on 2 major streams that have devolved into these 3 basic strategies. The first is to drive value-based purchasing across the community, starting with the state as first mover. The state as first mover was a message that we heard consistently as a high priority throughout our planning process. that the state both has an opportunity and the accountability, the responsibility really to lead with its policy, purchasing, and regulatory roles as needed. To improve chronic illness care, particularly through better integration of care social supports for individuals with physical and behavioral health comorbidities. Again, a strong focus throughout innovation planning, and building healthy communities and people through prevention and early mitigation of disease throughout the life course. Next slide, please. It has been an honor and a privilege for me to work with Dorothy Teeter and John Weisman, as well as Dr. Bob, on innovation planning. All three combine those rare qualities of visionary leadership, collaborative spirit, and deep operational and policy know-how. In this next segment, Dorothy will first discuss Washington's plan for driving value-based purchasing and physical behavioral health integration, and John Weisman will then discuss the plan's focus on early prevention and mitigation of disease throughout the life course. Secretary Quigley was unable to join us today, but DSHS has been a partner in innovation planning throughout, particularly around behavioral health integration. Dorothy?
Well, thanks, Karen, and good afternoon, everyone. It's really great to be back on the phone with all of you at this point in our planning process. I was looking at the slide that Karen put up in terms of the number of people that have been engaged in this process, and it's pretty incredible. I was just back east at a National Governors Association meeting with 40 states, and of course the topic of the innovation planning was top of mind of all of the CMS officials that were there, along with all of the states. And I think in my conversations with other states and with CMS, the value of the stakeholder process to get to the right answers and strategies for the individual states was very high on their mind. So very much appreciate your ongoing engagement with us. So what's in the plan? I think that the concept of the value-based purchasing across the community that starts with the state as first mover, as Karen said, that concept is one that has started with the governor. When we were talking with him, he said, well, we're going to be purchasing for up to 2 million people in the state of Washington. How are we setting the example of moving from purchasing for volume to value? How do we make sure that as we do that, people get healthier in their communities? So the concept of state as first mover, we have taken to heart in terms of everything we do in terms of the way we purchase care and the way we want to build communities to help us do that. I think that one of the things that's a hallmark of our plan is the integration or the work across both the public and the private sectors. It's not surprising that there isn't always a common viewpoint when you do that, but the richness that's come out of that discussion has been pretty awesome. So within, testing this strategy, we haven't had, as we've written this in concert with all of you, the goal of within 5 years to move 80% of state-financed healthcare to outcomes-based payment and work with the major purchasers of the commercial market at least, and potentially think about how we might engage our Medicare fee-for-service partners as well to move at least 50% of the commercial market from a fee-for-service to an outcomes-based strategy has been one that has seemed realistic. So, and in fact, in many practices, primary care practices, you hear folks say that they're already at 50% of their business is now in a managed, capitated, not fee-for-service sort of model. So I think we're moving faster than we may even think in that regard. Again, what's met with a lot of support is common measures, so that we're measuring the same things across the state. Really important in terms of not only sending common sort of market signals, if you will, but also so you decrease the administrative complexity for delivery systems who are going, okay, it's this health plan or it's the state or whomever, they want different measures, and getting down to a vital few that we can all use to improve and to measure progress. So I think those are some of the kind of really key points that we want to make on that. the more that we can align our measures, the more I think that we can innovate, so that if we're not spending our time running around measuring a lot of different things, but we're all as an entire state moving forward together, then there's a much greater opportunity to both innovate and customize within regions. I think that the one thing that has become more and more apparent as we've gone forward is the need for transparency. As we're doing common measures, we need price transparency, not only for purchasers, but also for consumers. You'll see in the legislation that Bob Crittenden mentioned earlier that there is an element of one of the legislation that we have around this plan that involves an all-payer claims database and the use of data to really inform our purchasing strategies. So again, that's a public-private effort to make the marketplace something that's everyone's friend in terms of moving forward with the best models possible. Next slide, please. The second goal that Karen mentioned again is the improving of chronic illness care and hopefully preventing chronic care to begin with, chronic illness to begin with, through better integration of care and social supports. And while it's important for everyone, I think that we know in our state that the time has really come to tackle a very difficult issue, but one that's got a tremendous evidence base underneath it, that when you really try to integrate both the payment and the delivery of physical and behavioral health in different models, but try to integrate it so folks that have a combination of illnesses or needs don't have to decipher a fragmented system to get the care they need, but rather they can go to one place to get that integrated care. It's just time for our state to do that. Tremendous amount of energy and excitement, as well as some trepidation going forward with this to see if we can do it in a way that keeps the patient at the center. If you're that person, what do you want? And really build our system around that. Obviously, this is something for Medicaid in particular. We're working hard with our partners at DSHS and with all of you on the phone to build something that makes really good sense at the community level and at the individual level for our health plans and also for our counties as well as our delivery systems, who at the end of the day are the ones that have to really take good care of these folks. So I think those are some of the key issues that we wanted to touch on there. Let's see if there's anything else I wanted to comment on here. I don't think so. I think this is a really exciting place, and I think it's one where, in my mind, we can make the most difference if we engage in a way that everyone, again, can win in this procurement going forward to do a better job taking care of the folks, as well as making sure that communities and counties have a tremendous amount of say in how things are structured. Okay. The last slide here is admittedly a bit of a busy slide, and this is one where we're beginning to talk through, okay, if we want to re-engineer or adapt, I guess, or change the way we finance and deliver Medicaid services that includes the whole population, taking into account the different needs for different subpopulations within that. And if we want to make sure that we're leveraging the assets that we've got in our communities across the state to help support a healthier population and each and every individual within that, how might we do that in a way that even that we can do a better job than we do now? So I think we're really trying to support change at both the healthcare system and at the community health system levels. That includes local government, it includes housing, it includes community-based organizations, as well as our healthcare systems, our behavioral health systems, and obviously, very importantly, our public health system. We're, based on the feedback that we've gotten, there's been many suggestions for more regions within the state so that you can really pay attention to the populations in various parts of the state and the structures that are there in order to support better health care outcomes as well as better health outcomes. So we're beginning to look at a structure that we can put into place that has accountable collaboratives of health within regions, linked in some ways to those that purchase health care, so that we make sure, again, if we're a purchaser, that we're not coming up with ideas for how to purchase and the performance that we want that you can't do unless you're worked with the communities themselves, which, again, as you go forward with innovation, you've got to push out our innovations to our communities. So development of the key elements of any kind of a competitive procurement process that we would do will include a very ongoing thorough consultation with our stakeholders, including local government, healthcare systems, and health plans, to make sure that there's effective and workable mechanisms to leverage the accountable communities of health, collaboratives of health, with the rest of our Medicaid program to achieve the three-part aim. So again, I think I want to make sure that we say that we've gotten a lot of extensive feedback throughout this plan. In this particular area, we think we'll have more as well. And now I'm going to turn it over to John, who's going to continue talking about what's in the plan. John?
John, are you with us? John, can you hear us at this time? Dorothy, maybe in the meantime, do you want to begin walking us through the Accountable Collaborators for Health concept?
Sure. And John, if once we get you online, you just feel free to interrupt me, and I'll let you take over. So the reason John and I wanted to share this section was because it's very important that people understand, and we continue to build this linkage between population health, and healthy communities, and healthcare system, and the folks that receive health care. Really an important message that we want to send. You can see that our agencies will be working together as well to do the gap closing that we need to do in terms of our population prevention, primary care, physical health, and behavioral health, along in tandem with the public health and social and human services. We have to work together across all elements of our community infrastructure. It requires alignment at both the state and the community levels. If we're going to invest in the success of healthy communities, the state will be leveraging its leadership role to help align policies that provide the opportunity and space to develop healthy physical and social environments for those resilient communities that we need. The health in all policies concept is one that's going to be really important for us as we go forward. So as we think about everything, every decision we make, it relates as much to how is this going to affect the health of our communities and the people that live inside of them.
Can you hear me now?
Now, John, it's just a good handoff to you right now. Can you hear me?
Yes, I can. Apparently, it didn't work on my headset.
I was just going to start talking about the accountable communities of health, but it's all yours.
Great. Thanks, everyone. And I want to actually thank Dorothy and the leadership of the Healthcare Authority. One of the things that's exciting for me as the Secretary of Health being involved in this from the earlier version of this is that really folks have said looking at health overall is really important, and thinking about communities and community health and how we have to close this gap between clinical and medical care delivery and the public's health has been really exciting about this. And the way in which this plan has us doing that is really focusing on these accountable collaboratives of health. In the grant that we submitted, you'll know that we called those accountable communities of health, and we've switched our language to collaboratives to really, I think, emphasize what it is we're believing the power is of these, which is really trying to get collective impact of multiple organizations coming together, working towards the same goals. So in terms of the accountable collaboratives for health, we know that healthcare is delivered and experienced locally in the communities where we work, live, and play. And certainly I told that to the governor in my interview for this job. Accountable collaboratives of health will provide this regional framework for innovation, greater community involvement in Medicaid purchasing, and enable the cross-sector approaches that achieve the triple aim of cost reduction, improved patient experience, and better population health. And going on to the next slide, this really isn't something that we created on our own. There was a lot of momentum already occurring throughout the state. So one of the impetuses for the ACHs really was building on transformation structures that were already sort of taking root, grassroots, in parts of the state where regional folks were coming together and asking how it is they as communities could look at health from a broader perspective and leverage the systems, the people in systems, the resources to achieve both better clinical care and handoffs and care management to the community supports that are needed for health. So really, these efforts, as you can see on this slide, really have been cropping up all across the state. Some of these occurred certainly well before this grant. People were looking ahead. Counties certainly were looking ahead and saying, how are we going to assure that our populations, that the most vulnerable, are going to be served in this new system and reduce impact on county services, whether that be jail health services or other services, and bringing together things like housing and human services together. So this map shows that there was already a lot of regionalization and collaboration going on. And as this grant has been written, more folks have been forming these kind of associations to take a look at how to address community health. In the grant, as we look at it, we're looking at forming somewhere between 7 to 9 regions, and we can go to the next slide as we talk about this next piece. So these were the 7 straw man regions that were proposed in the grant, and recognizing that this is still a straw man, there is a lot more discussion that needs to be had with folks about what is the best makeup of regions that we might move forward with in the next phase of this. What I wanted to focus a little bit on here is what accountable communities of health can do and what they are and what they aren't. So, and I said communities again, now it's collaboratives. ACHs can provide both this community and social support linkages to the delivery system in a more intentional way than perhaps we've been doing in the past. The philosophy and structures of the ACHs is built on the notion that there are many contributors to health besides health care itself, and that with formal recognition and state support, ACHs can be empowered to take a proactive role in helping achieve this triple aim alongside state and other purchaser entities. And the interest in this from private philanthropy is strong and an important component, I think, of moving these forward. The collaboratives are meant to be local in their nature and flexible, to build on these regional efforts that have already occurred that you saw in the last slide and the collaborations that are taking place, and to provide more formal state support to ensure the success of these at meeting the whole health needs of the population they serve. It's important, I think, as I alluded to also say what are ACHs not. So they're not intended to be a one-size-fits-all approach. We understand that different collaborations have different opportunities. We understand that there are differences between rural and urban, between the provider networks that folks might have in place, and who provides what kind of services in the community. So we're really looking for this to be locally driven in terms of what those sizes or what those ACHs need to look like. They're also not intended to act as a regulatory body or add administrative layers. ACHs are intended to bring entities together, though, and align resources that are sometimes unaligned and duplicative. And essentially, this is really trying to build off the framework of collective impact and how one has a backbone organization to support the collective and to help facilitate the impact that multiple players can have. The other thing that ACHs are not intended to do is to supplant government entities such as local public health jurisdictions or roles of counties or folks in housing and human services. They're also not intended to divert state general funds that are otherwise going to local entities. We think it's important that we keep funding local entities with the work that is currently happening. ACHs are intended to mirror regional service areas, as Dorothy was talking about for Medicaid procurement, to ensure adequate alignment and leveraging. We're also looking for regions that promote sustainability, especially as it relates to the number of covered lives, for risk-bearing entities, and ensure adequate reflection of the natural referral patterns that are already there in communities. While each regional service area will have one ACH, this doesn't suggest that local communities can't have or continue additional improvement organizations or initiatives, because really we think driving action at the local level while aligning and leveraging best practices across the region and the state makes sense. So one of those examples, I think, is, for example, community health assessments, and encouraging community health assessments, for example, to occur as they do now with hospitals coming together and public health agencies coming together to do that, and then think about in a region, are there similarities between those communities and some things that really would best be served by a regional response. So we believe there's room for both that local and regional work there. In terms of Medicaid purchasing, we envision a consultative and proactive role for ACHs in all phases of the procurement, building on the success of the fully integrated duals demonstration project with King and Snohomish counties. This is necessary, we believe, to make inroads on behavioral health integration and fully leveraging community assets to better serve our vulnerable Medicaid population. While this local collaborative and consultative approach is important, the state will retain the ultimate decision-making responsibility for contractor selection and performance oversight. And with that sort of background on ACHs, I'm going to turn it back over to Karen.
Great. Thank you so much, John. So this is just a snapshot of our current system and where we hope to be in several years. And the elements are the ones that we've been talking about throughout. So delivery systems positioned to better address prevention and link with social determinants of health. Support at state and local levels for practice transformation that emphasize team-based care. We really haven't talked too much about that, but that's an element that's embedded in the plan. An emphasis on regionally responsive payments and delivery systems driven by integrated purchasing of physical and behavioral health services by the state. State leadership in deploying innovative purchasing models and really moving to value-based payment where it is appropriate. Alignment between public and private purchasers around common measures of performance with value-based payment more as the norm, as Dorothy was talking about. And as Dorothy began, a transparent system of accountability allowing purchasers, consumers, providers, and plans to all make informed choices with the same types of apples-to-apples information. So I'm going to now, next slide please. We have some time slotted for questions and some feedback. And I'm going to kick it off because since I have the podium, I'll take the privilege of asking Dorothy and John a question first, if I may. So Dorothy and John, starting with Dorothy, what have been the major aha moments for you during innovation planning? And why do you see the accountable collaborative of health as important to our progress? Dorothy.
So I just came back from almost 20 months in Baltimore, and when I came back, having been here in the States, One of the aha moments for me was actually that map that John put up that talked about all of the regional collaboratives that had really pretty much sprung up over the last couple of years.
I think it's
was
on there,
really,
not ours. So we were able to get me off the headset and use my handset. That worked. But then I think I got this.
Hang on a minute, you guys. We got two people talking. He's muted. Okay. So the aha for me was, and having been steeped in innovation thinking when I was back at CMMI, was how quickly people were moving out into the community to really leverage better health as well as better health care. I think the other aha for me was the readiness now after almost a decade of coming up with different measures and ways of measuring performance, that people are really ready to come up with one common set of measures, and that the next level or platform of innovation is going to be, once we get there, then we can move ahead to innovation at the next level.
Great. Thank you, Dorothy. Same question to you, John. What have been your aha moments, and why do you see the accountable collaboratives of health as important to progress?
We're having a situation at the moment where John hasn't been able to hear us since he finished speaking, so we're trying to resolve that. And as soon as we figure that out, we can text him the questions and he can answer.
Okay. Well, that might make him a little more difficult for him to answer questions. So maybe we'll come back to that, unless, Bob, would you like to give the question a shot? What's been your biggest aha moment during innovation planning?
Around the collaboratives, to me, I had actually known about these organizations in the different parts of the community, different communities. But one of the things that's always been a stretch is how do we actually integrate what goes on in a clinical setting with what goes on in the community. And I think the creativity of the thinking here about having these collaboratives where we have representatives of different groups looking at ways we can identify problems and problem solving over the different platforms, different silos, is really, I think very creative and something that, I know in my own work in both practice as well as policy that it's been it's been unknown. I haven't really been able to figure that out, and I think this is a worthwhile thing to really try to make it work right, and I think it's real potential for us to do that.
Great, thank you. So if we do not yet have John back,
We may have. We're going to check here in just.
Can you hear me?
Oh, there you are. So John, can you hear me?
I can.
Great. So I was going to throw a question your way, which has been, what have been your major aha moments during innovation planning, and why do you see the accountable collaboratives of health as important to progress?
Well, one of my, I think, aha moments actually occurred back in Washington, D.C. When a number of us were back there last week with the other CIM grants. And I think that aha moment is that when we look at populations, we in public health obviously have jurisdiction for entire geographic areas, whether that be counties or health districts. And one of the things that I think we need to work towards and bridge is that healthcare systems are often looking at smaller populations, whether it's the Medicaid population, the patient panel, et cetera. And we've got to bridge our interests and desires appropriately of looking at population health from this large geographic area to thinking about subpopulations in there and how do we partner with various partners to improve population's health that they might see in smaller groupings. And that bridging of going from what an individual health care provider or health system might see to population health is part of the work that we have to do together.
Great. Thank you so much. I'm now going to turn to Laura Zeichkin, who's been tracking questions that have been coming in. I think we'll probably only have time to take a couple of those questions. But Laura's going to serve them up, and I'm going to dish them out to our various leaders here today.
Great. So we've received several questions, and I'm trying to lump them in order to get the most out of this 5 minutes or so of Q&A. So some questions that we're receiving really have to do with that graphic that was shown about the RB-ACH relationship. And so can you explain a little bit more about how HCA will contract with the risk-bearing entities, and then also how then the RBs and the risk-bearing entities and the accountable collaborators for health, how that relationship will work, particularly as a collaboration and not necessarily as giving authority over the risk-bearing entity.
Terrific. And recognizing, I think, that there's still quite a bit of activity and work to be done, bridging from our conceptual models to on the ground. How is this all going to work? I'm going to look to Dorothy to get that one shot.
So great questions, and I think you must have been sitting in our offices over the last several months as we've been asking the same question. I think the key construct here is that the recognition that neither the healthcare system nor the community or community health system by itself can achieve the three-part aim of better health, lower costs through improvement, and better care. So the question really is, as Bob Crittenden said, if you're a clinician, you're sitting there going, geez, if only I could write a prescription for healthy food, for example. Or if you're in the community, you're going, why is it that that patient just left their Medicaid office or their healthcare provider office, and they didn't tell them all about the services that we provide. So it's this ability to link what we need to take care of a person for their overall health, not only their healthcare needs, which I don't want to ever think that that's a small piece of this, because it's huge, a lot of money, and it's extremely important that you get the best possible care possible at the time that you need it. But also that backdrop of how do you make sure that you're staying as healthy as you can for as long as you can. So I think the idea is that you would want to potentially over time, if you're investing a little more in the health of the population, you most likely aren't going to need as much money over time in the day-to-day or ongoing health care needs, because the population's healthier, they don't need to come in as much. So I think it's that kind of a linkage, as well as linkages around, make sure you get your immunizations or your flu shots. How do you leverage both the community to send that message as well as your clinical care system? How that would work in terms of actual contracting, I think, is probably the next round of discussion we would want to have with all of our stakeholders. If you're in county government, you're going to be extremely interested in how the mental health and physical health contracting would go, and we need to be paying super close attention to that. So if you are already an accountable collaborative and you want to be an accountable collaborative, we want to understand what you're doing now and what that would mean in the future. So I think the next round is really to operationalize those levers that are going to be the most effective in working across, and we do not have specifically tailored answers yet, because that work is still yet to come.
Thank you, Dorothy. Next question.
I think the next question builds a little bit upon, Dorothy, what you were just speaking to, but really it's about how the innovation plan touches on how attention and the whole person. So what does this look like from the social determinants of health all the way through prevention, particularly across the life course? And then also, how does legislation play into ensuring that we're delivering whole person care?
Great. Well, so I'm going to suggest that John kick this off for us. And if I might, John, one way that you might want to think about framing a response is on considering a person with serious behavioral health and physical comorbidities, and looking back over that person's life course. What is it that could be done at the very earliest stages to help prevent or mitigate those issues, and how might better orientation to prevention and community health serve those persons and families better all along the lifespan?
Right, that's a great question, and I think it's really the heart of what we're trying to get at when we think about health in the broadest sense here. In many ways, we're certainly looking at starting with preconception health, and how do we assure that the health of women, for example, is the best it can be. And clearly, that's the bringing together of not only preventative care services that someone might get in a clinical setting and assuring that folks aren't smoking, that they're eating healthy diets, but it's also about how we're interacting with educational systems and ensuring that folks are completing high school and having that best opportunity to have a resilient life. And so we're starting and thinking even preconception when we think about the lifespan work that we're trying to tie into this work. And then as we look at a woman, for example, who is pregnant, again, making sure they're getting the preventative clinical services and getting the necessary supports that they need, whether those are family supports. And again, these are things communities do in terms of sort of helping to provide this care across education systems, child care systems, and the whole range of health and human services, so that we actually are giving birth to healthy kids that have supports for breastfeeding and immunizations. Again, these things go back and forth between clinical care systems and health and human service kinds of systems, and looking at adverse childhood experiences and the work, the research that we know that says kids who grow up in households with a large number of ACEs really have high risk for long-term chronic disease. So, and that includes sort of mental health and behavioral health kinds of needs down the road. So really trying to focus on a prevention system.
That's a great example. Thank you so much. Time is short, unfortunately. We could spend a lot more time, I think, having a back and forth with questions and responses. But we do want to leave time for bridging. Next slide, please, which is bridging from planning to implementation. I mentioned earlier what a pleasure it's been to work with Dorothy and John and Bob. It's been an equal pleasure working with the talented Laura Kate Seichkin, who combines deep knowledge and project management skills with a natural bent for tact and diplomacy, which has been invaluable during our innovation planning process. Laura is going to talk briefly about bridging from planning to implementation. Laura?
Thanks, Karen. So I think it's been really clear throughout this webinar, the innovation planning process, and in the innovation plan itself that we've outlined with your help and feedback specific aims and strategies, but the path and the methods to really achieve them aren't fully developed yet. And that's really for a good reason. We want the path forward for us from planning to implementation really will rely heavily on continued input and partnership with our public and private thought partners, so you and others who have been engaged throughout the last 8 months, and those who have yet to come to the table. So with the innovation plan in place, we're really working on a strategy to develop and expand upon the plan strategies to put together specific implementation plans, really, again, relying heavily on collaboration with you and others as our partners. John and Dorothy spoke quite a bit about the CMMI CDC convening that we attended in DC last week, where they really put a heavy emphasis on ensuring that all states' innovation plans and future implementation of those plans focus on these partnerships between population health and the communities to make sure that we're addressing the health of our population. And so we're really putting a priority on making sure that those elements of the innovation plan are being focused on and fleshed out over the next several months. So more information to come on how you can be a partner with us in thinking through how the, accountable communities of health may look may be governed, as well as the regional service area discussion that's really heavily engaging counties and other partners. I do want to take a moment to look forward to the anticipated funding opportunity announcement from CMMI. This entire time we have been putting together an innovation plan that the state has intended to implement regardless of federal resources. However, we do know that federal resources are coming. What they'll look like, we're not quite sure. We do know that within the next few weeks, we expect to see a funding opportunity announcement for round 2 of state innovation model grants. And so we're watching for that. We're working closely with CMMI, and we will plan on building upon the innovation plan and working very closely with our public and private partners to develop out the grant application to implement this.
Great. We are out of time. Time is flying. Just wanted to thank you all, including our incredible roster of consultants and the many of you who are experts out there in your communities and statewide and on a national basis who have contributed so generously to this plan. For all of you, please do read through the final plan and be thinking about your role in driving its success. Thank you all, and here's again the website where you can get access to the plan and share any further thoughts that you have as we go forward. Take care, everyone.